comments, I invite the next speaker, Dr. Shiv Bagga. He'll be talking to us on his case of left main coronary bifurcation stenting. Dr. Shiv Bagga from Chandigarh.
I'll be just presenting one case of left main bifurcation stenting. We had two excellent lectures by Professor Sethi and by Dr. Haridas. I'll be just demonstrating the technique of sleeve technique, or the double kissing crush technique for a left main bifurcation. My patient was a 75-year male, a hypertensive patient, and a known case of coronary artery disease with an old anterior wall NSTMI, and had a stenting done to proximal LAD around 2 years before presenting to us. And this time he presented with unstable angina. So this is the angiogram, which showed a true bifurcation lesion involving the left main bifurcation. We had a very critical lesion in the ostial LAD and a disease in the circumflex, which was a dominant circumflex. The right coronary artery was totally occluded. Now the conventional treatment for these patients obviously will be surgery, but there have been recent changes in the guidelines for left main stenting, especially with data coming from the Korean group of Dr. Park. But what about this case? Well, at least there are certain indications or settings where PCI is better than CABG, and when we do have data from the main compare registry from Dr. Park's group. But what about this case? He had a favorable syntax score. The Euro score was not that bad. But we have certain considerations, especially in Indian settings. We don't have the, real luxury of having IVUS. Then we have issues of dual antiplatelet therapy in old patients, and obviously the angiographic surveillance, which is a real issue in our country because most of the patients don't agree for check angiograms or follow-ups. So I initially referred this patient for surgery only, but the surgeons actually refused, considering the high risk. And in addition, the patient's attendants were also not willing, although we usually take it as a convenience score rather than syntax score for justifying left main bifurcation stentings. But the issues regarding PCI, we had to decide regarding which was the best two-stent strategy, and in such patient, which two-stent approach is optimal. There definitely are subgroups of patients with left main bifurcation who have to be subjected to a two-stent strategy, as from the data from the main compared registry. So I chose a two-stent strategy for this patient, considering the left dominant circulation, a long side branch lesion in the left dominant circumflex, and a large area of myocardium at jeopardy. The second question was which two-stent approach to choose from. As shown by Dr. Haridas, we really don't have any evidence base on which strategy to choose from. But we do have some pilot studies like the DK crush study which has shown actually that DK crush stenting may be superior to the conventional crush. Although we have data from the Nordic bifurcation 2 showing superiority of Q-lot, but the drawback was the final kissing balloon was done lesser in the crush stenting group. But the baseline remains that we have to perform a very optimal procedure and finish the procedure with a good final kissing balloon strategy. That is the basic fundamental of doing a bifurcation stenting for left main. Well, we can choose from Q-lot or crush or a DK crush, which is a modification of the crush, and I'll be demonstrating this technique, which actually involves 5 steps. There are 2 additional steps in addition to the conventional crush. So I decided to perform the DK crush stenting for this patient. I deployed a 3 millimeter cipher stent, 3 into 33 millimeter cipher stent in the circumflex. A balloon was parked in the left main to LAD, which crushed the left circumflex stent after removing the balloon and wire from the left circumflex. And subsequently, the first dilatation of the ostium of the circumflex was done with a non-compliant balloon. Subsequently, the first kissing balloon dilatation was done, and this is the result after that. And after that, I deployed the main branch stent from the ostium of the left main to the LAD, which was a 3.5 into 28 millimeter cipher stent. And this is a result of the main branch stent. Subsequently, I post-dilated and proximally optimized the stent and recrossed again the circumflex and dilated it with an NC balloon at high pressures, and a second kissing balloon dilatation was done. And the left main stent was further optimized by a larger size non-compliant balloon based on the Murray's law, because we had deployed 3.5 and 3 millimeter stents respectively in LAD and L6. And this was the final result. This was the 9-month CT angiogram. The patient didn't agree for the conventional angiogram. It showed patent stents with well-deployed stent in both the LAD and LCX. And I have a 29-month MACE-free clinical follow-up on this patient. Thank you.